Hi everyone, welcome back to our regular classes. So previously we were discussing about the digestive system, but I think that it's becoming boring because at a stretch in a week, for a week we are discussing about the same organs, esophagus, stomach. So I thought that it was becoming monotonous, so I thought of changing the subject or topic for a bit. So 1 week we will discuss about the critical care nursing, then again we will return to our physiology. So I decided to teach you some basics. These are not the basics but regulars, some checklist we see when we just enter in the ICU, because they are very important for the patient and for the patient prognosis and also for the documentation of the institute. So just for a brief review and recap of your syllabus previously discussed in your academics, I will today discuss about the bundle care. Now we will discuss about it. So from the term bundle, we can understand that bundle is nothing but group of something. These are mainly 3 to 5 evidence based practices, not like in the air we are not practicing any practices, but these are supported by research, studies. Previously research studies were going on, and there are also ongoing research studies which are doing research about practices which helps in the improvement or better outcome of the patient prognosis. For better outcome of patient prognosis. Okay, so it had been seen that when we practice this simple practices in the critical care unit or in the unit where there are critical patients, like in the dialysis unit where in the chance of infection increases, so it has been seen that the prognosis of the patient or the infection level or the betterment of the patient is getting day by day better when we practice this all simple steps. So mainly in the bundle care we have, first is the VAP, that is ventilator associated pneumonia. Second is the CORTI, that is catheter associated urinary tract infection. And third is the CLABSI, central line associated bloodstream infection. Fourth is the pressure sore prevention. There are many more like sepsis bundle, but the most important are these 4, because when you are getting admitted in a hospital setting, the main infection which affect you comes from these 4. That is, if a patient is seriously ill, he goes to the ventilator, and that becomes the main risk of his life. So from a life support to getting out the patient from the ventilator, it's been a long journey. So now we will discuss about the practices which we will follow to prevent all these infections. First we will discuss about VAP. So this is ventilator associated pneumonia. Okay, so first we will see that the sources of VAP pathogens. First, VAP pathogens mainly comes from the healthcare workers. Suppose this is the healthcare workers, and this healthcare worker goes to the wash basin to wash his hand. then goes to the medicine trolley to administer medicines to the patient. Third, he goes to the other ICU patient, because when you are working in a ICU, either you will get 1:1 ratio patient, otherwise you will get 1:2. That is, every one nursing officer is assigned for one patient, otherwise one for two patient. Then this nursing officer is getting contaminated, or healthcare worker is getting contaminated hands and apparels, which is carried to the other patient when he goes to the other patient who is also at risk to get infected. Next comes contaminated respiratory instruments. First comes the humidifier fluid, second is the suction catheter, third is the ventilator circuit, fourth is the bronchoscope. When a patient is in ventilator, we cannot change the circuit every day, so the circuit is being used for 3 days, 4 days according to the patient need. So when the patient is fully on life support, in the circuit there are debris of secretion which acts as a home for the spreading of infection. Third comes our own body, that is oropharyngeal colonization, gastric colonization, aerosis. Inside of the patient there is a stressful situation, and there are already infection inside the body, so they are mainly collected in the gastric region, and that gastric colonization occurs, which increases the chance of the infection. Second is the aerosis, droplet, cough of other patient. These are the mainly sources of pathogens. Next we will see that how we will prevent these VAPs. Okay, so next we will see how we will prevention. First is the hand hygiene. Hand hygiene is the most and utmost need you have to follow when you are in a hospital setting to prevent cross infection from one patient to the other. Hand hygiene will follow hand washing and 5 movements of hand hygiene. 5 movements you all know: before touching the patient, after touching the patient's surrounding, after doing any procedure, before doing any procedure. Okay, so next is the elevation. Head of the bed elevation for 30° to 45° angle. If not contraindicated, this should be mentioned, because if the patient indicated. Okay, third is the orogastric feeding is preferred more than nasogastric feeding, because nasal region is mainly directly connected to our brain, so any infection can travel from our nasopharynx to the brain. So orogastric feeding is preferred over nasogastric feeding. Fourth is the oral care. Mouth care should be given with at least greater than 0.2% chlorhexidine solution for QDS, like for every 6 hourly, 4 times a day. Next comes our PVD prophylaxis. PUD prophylaxis, that is peptic ulcer disease prophylaxis. Mainly here we use proton pump inhibitors. Okay, then ET cuff, endotracheal cuff pressure. They should be between 20 to 30 centimeter of H2O. Next is suctioning. We should do suctioning as per the patient secretion. Okay, regularly as per need. Spontaneous breathing, there are mainly 2 SBT and SAT. This is called SBT and this is called SAT. Spontaneous breathing trial means we have to do weaning of the patient every day if the patient is tolerable. Like we have to disconnect the ventilator from the patient, because otherwise the patient will always be in a life support. So to do the patient to maintain the patient outside of the life support, we have to do regular weaning under our close supervision. And last point is spontaneous awakening trial, SAT. This is also called sedation withdrawal. Okay, now so these are mainly the prevention methods we should follow to prevent ventilator associated pneumonia. This is the chart we follow in ICU to monitor that the patient is prone to VAP or not. Parameters you can see: temperature, WBC count, tracheal secretion or sputum, oxygenation, X-ray, chest X-ray, progression of chest X-ray after 3 days, culture of sputum. Then last we add our CPI score, that is clinical pulmonary infection score. If the score is greater than 6, then the patient is in favor of having ventilator associated pneumonia. For this, what we have to do, we send samples, both blood and sputum, because in blood we have to see the WBC count and in sputum we have to test the culture of the bacteria. Next we change antibiotics, but not over the next 72 hours, because the patient is already on the antibiotics, and if we send the sputum culture, it takes 72 hours to come the result of the culture. So after that, if the bacterial count is more, we can change the patient antibiotic, otherwise we will continue with the previous one. Last is the oxygenation worsening is most sensitive indicator. If the patient's SpO2 falls below, if the patient's SpO2 falls below 80% or 85%, or according to the patient condition, then the sensitive indicator is the oxygen worsening. That is, we have to check patient's SpO2 at regular interval. Okay, so this is mainly about the VAP, ventilator associated pneumonia. Next we will come for the central line associated bloodstream infection. Central line associated bloodstream infection. Okay, first we will see in this picture there is many invasive lines. First is the peripherally inserted central catheter, PIC line, which we tell arterial line catheter, arterial line, peripherally inserted catheter. Then is the last central venous catheter. Now in the central venous catheter, which vein is most preferred? First preferred is the internal jugular vein, then is the subclavian, then last is the femoral. Femoral vein is the least preferred vein because it is the longest, and the chance of infection increases if we do central venous catheter in femoral vein. Next we will see that there are mainly two ports when we do a catheter, IV catheter. First is the extraluminal route and second is the intraluminal route. Extraluminal route is the site of the pinprick, site of the catheter insertion, which is the predominant source of infection. At the time we prick the patient, that is the time the patient is prone to having infection, hospital acquired infection. Okay, then comes our intraluminal route, that is the hub through which we inject medication. That predominates after a more extended dwell time. After staying for 1 day, 2 day, 3 day, that hub becomes the infection site. But first, the extraluminal route is the first infection site route. Next we will see that central line insertion bundles. Okay, what rules we should follow to prevent the infection? First is the hand hygiene. As always, we should follow hand washing, 5 movements of hand technique. Then skin antisepsis greater than 0.5% chlorohexidine. If the patient is at least 0.5% chlorohexidine, we have to prepare the skin. If the patient is are having any allergic reaction to chlorhexidine or anything, then we can use 70% isopropyl alcohol. 70% isopropyl alcohol to scrub the skin. Then we will do the catheter insertion. Maximal sterile barrier precaution. Maximum personal protective equipment we will use while doing the procedure, that is last sterile labs. Instead of small sterile traps, we have to cover the patient totally. Then otherwise we will use mask, cap, sterile gown, gloves, etc. Then comes the avoid the femoral vein, as we discussed earlier. Next, what we will do, we will use a silk suture to stabilize our catheter. Next, we will use transparent semi-permeable dressing. Not transparent dressing will help us to see if there is any leakage of blood or any other discharge from the insertion site. Next, a 4 lumen, we will use a 4 or 5 lumen central venous catheter in ICU in unstable patients. This is a very important question which have come in the NORCET. Port 1 is for IV flush or bolus, port 2 is for vasopressors, port 3 is for the antibiotics, and port 4 for TPN or blood products. Now the maintenance bundles. Assess need for catheter daily. Second is perform hand hygiene. As manipulation of IV system, hand hygiene is very important. Dressing change recommendations and guidelines based on dressing type. Fourth is IV tube administration set, secondary set, and add-on device change guidelines based on medication, product infused. This we will discuss. The disinfect IV access ports with appropriate disinfectant for a period of time. We will not use any ointments or any other antiseptic to clean the insertion site. Now you can see two pictures, factors predisposing to CRBSI, and both are the factors which are predisposing the patient to have central line associated bloodstream infection. So what we should do, replace every central venous catheter. If the central venous catheter is short term use, at least 7 days, continuously usable 96 hours, that is 4 days. After 4 days we have to change it, and if any blood products are used, then we will discard it then and there. NS flush, this is also question which have come in your NORCET. NS flush every 6 hours we have to do to check the patency, of our catheter. So these are all the prevention technique we will use. Now comes to the COTI, catheter associated urinary tract infection. I wish you people cannot see, sorry. Now you will be able to see. So urinary tract infection, catheter associated urinary tract infection is the most common nosocomial infection when we get admitted in a hospital setting. Preventing COTI, how we get prevent? Avoid unnecessary urinary catheters. So how we will avoid unnecessary urinary catheters? These are the external condom catheters for appropriate male patients. If the patient can tolerate condom catheter, so we can give the patient condom catheter rather than invasive catheters. Like for specimen collection, we will not just insert a catheter to collect specimen. Okay. Next, intermittent catheterization multiple times per day. Third is assessing urinary retention with bladder ultrasound. We will see that the patient can tolerate holding urine, so that we can remove the catheter and the patient can void on her own. Second is insert using aseptic technique. Now in the aseptic techniques, first we will always hand hygiene first. Second, aseptic sterile equipment we will use gloves, drapes, sponges, sterile antiseptic solution for cleaning the urethral meatus, antiseptic solution. Okay, single use packet of sterile lubricant jelly for insertion, that is one time lignocaine jelly we will use. We will not use it on other patient or on that patient on the next day. Use a small catheter as possible that is inconsistent with proper drainage to minimal urethral trauma. Okay. Third is maintain catheter based on recommended guidelines, daily care. Maintain a sterile, continuously closed drainage system. Like if we want to collect patient urine who is on catheter, then we have to collect the urine from urine port, not from the urinary bag or any other portion. Keep catheter properly secured to prevent movement and urethral traction. This you can see in this picture. The catheter is placed above the patient, but this should be placed below bladder level, and should not end off the floor, should not touch the floor of the hospital. Now this is also, there is seat catheter fixation, but catheter fixation should always be over the thigh and should not hang here and there. So keep collection bed below the level of the bladder. Maintain unobstructed urine flow. Yes, we should see that there is no other kinks in between or any other obstruction in the catheterization. Empty collection bag regularly. Collection bag we will empty when it is 3/4 full. Next is the review catheter necessity daily and remove promptly. If we will see if the patient is in need of catheter or not, otherwise we will remove it. Last is the our pressure sore prevention bundle. There is nothing here. Pressure sore prevention we already know. First we will see that the patient is rotated every 2 hourly. Okay. Second, we will see that no kinks in bed sheet, that is wrinkle free bed sheet. Third, we will see there is back care. We should give back care regularly as per need. Then what we will see, air mattress we can use, air mattress. Now nutritional management, that is increased protein diet, vitamin C. Okay, then we will assess if there is any bed sore. Then we will assess the level of bed sore, its grading we will do with Braden scale, and report to the healthcare provider. So bed sore prevention is nothing, we all know that how to prevent a bed sore. So these are mainly the bundle care we need to follow when we get posted in our ICU, that is intensive care unit, because there are majorly serious patients admitted over there, and they are at high risk that their short span of life is very short. But with our practice and care, we can really help them and make their dear ones once again happy to have them back at their home. So we should maintain all these practices and practice them at the hospital, so that the patient prognosis or outcome becomes so good. So today's class I will end here, and because I need to go to sleep and I have work tomorrow. So I wish you people have understood. If there is any question, please do comment in the comment box. For today, bye, and I will discuss another topic tomorrow. Good night.